Start from the point where we had stopped in the last session. We are discussing about the Sivana Shastrakarma. In the Sivana Shastrakarma, the next part is about the technique of suturing. How to do the suturing and what are the suturing materials. Tato vranam samunnamya sthapayitva ythastham sivyet sukshmena sutrena valkena ashmantakasya va षडज क्षौमसूत्राभ्यां स्नायवा बालेन वा पुनः मूर्वा गुरुची तानेवा सिव्येत् विरलितकं शनैः. Now, to do the suturing materials are required, and the suturing materials suggested by Sushruta are of quite wide variety. They could be either of plant origin or they could be of animal origin, and some of them are absorbable and some of them are non-absorbable. Ashmantaka Balka, that's the shana as such, and then the Kshauma, silk. These are the non-absorbable plant origin suturing materials. Snayu, tendons or hairs of animals, they were absorbable and animal origin materials. In addition to that, Murva and Guruchi, these also were used as suturing materials. With the Murva fibers, a few trial work was done, and that Murva fibers have promoted healing, like this is what we have seen, promotes healing, and they actually would have comparatively less irritation compared to the cotton as such. But one of the problem with the Murva is it's a bit more fragile. Now anyway, in the current situation, what we have is a quite wide variety of suturing materials, which again can be classified in the same manner as absorbable and non-absorbable. And again, in the absorbable, you have either natural or synthetic. And in the synthetic variety of the absorbable, mainly the collagen fibers, like what we call as catgut. These are the natural, this variety of synthetic variety of absorbable substances. Naturally, you have the collagen fibers of animal origin. Synthetic, monocryl, bicryl, etc. The other substances, non-absorbable, and what we call as catgut is also a partially semi-synthetic substance which is used for the absorbable suturing material. And in even the catgut, you can have a coating of metals, so that chromium metal can be having a layer, and hence the duration of the catgut in the body can be enhanced. So you will have different variety of chromic these catguts, where it can be enhanced up to 3 weeks. So duration taken for the absorption can be enhanced. Non-absorbable sutures, again, among the natural, it's mainly the cotton and the silk or steel, or whereas synthetic, ethylene, proline, these are the non-absorbable materials which are used now. Now, the technique of suturing are Sivyet Gomphanikam Vapi or Sivyet Vatuna Sevanam, Rujigranthim Atovapi, Yatha Yogam Athativa. The suturing techniques also are described by Sushruta as the different varieties. One of them, of course, is the Velitaka. Velitaka is a simple continuous suture. And then the Gophanika is where you will have a mattress sutures. In the mattress sutures, again, you will have two varieties, either horizontal or vertical mattress sutures. These are the ones where you will have the needle will be moving in two tracks, and one part of the track will be hidden below the tissue, and only the two components are seen over the surface. And because of this, it gives a appearance of a hoof of a cow. It's named as a Gophanika. Velitaka is a simple continuous suture where you will have a continuous suturing as such. And the Rujugranthi are simple non-continuous sutures, simple knots, where you insert the needle and there is a single movement of the needle and then suture. The advantages and disadvantages of these suturing techniques are, when you have a mattress suture, the pressure along the edge of the wound over the surface as well as the depth will be equal. Whereas when you put a simple knot as such, or single knot as such, the pressure over the edge would be, superior surface of the edge would be more. Comparatively, at the deeper level, the pressure would be lesser. So if it is a very deep wound, it's always better to have a mattress suture. If it is a relatively superficial wound, then a simple suture could be used. With the continuous suture, the advantage is it produces a uniform strength or uniform stress along the length of the wound, whereas with the interrupted sutures, as we use both the single knot or maybe the mattress sutures, the pressure along the wound edge, the length of the wound may not be same, because by the time you tie the knot, at some areas the pressure may be more, some areas the pressure may be lesser. So this may produce a irregular scar. But with the continuous suture, one problem, because it's a single thread which is along the suture line, if at all this thread breaks up, then the whole wound will be dehisced. Whereas with the interrupted sutures, you have the advantage of security. Even if one or two sutures are broken or damaged, then still the wound can sustain. So the selection of this technique would be based upon the situation where you are operating upon and the possible stress on the wound in the postoperative period. Then the Tunasevana is a subcuticular suture, where the suture thread will be below the skin and virtually invisible for a long duration. This gives or till the wound heals. Then it's just a subcuticular crisscrossing movement of the needle in the subcuticular area, and then once you pull, it gives a uniform surface of the wound, and the scar will be very minimal. But one of the problem is it doesn't cover the depth of the wound, and you will be using more suturing material, and injury to the tissues would be more when you use the subcuticular. But still, in many of the cosmetic surgeries, the subcuticular suture is preferred. Then Sushila even gives the details of the needles which are to be used for the suturing techniques. And the needles are, again, Sushila has mentioned about 3 varieties of the needle: Vritta, Ayata, and Trasra. Now, Vritta is a circular bodied needle, round bodied needle. With the round bodied needle, the tip of the needle is sharp, and then body is round, and hence as it is pushed through the tissues, as it passes through the tissue, it doesn't produce injury to the, or it doesn't cut the edges, but the cells in the surrounding area would be pressed. As the tip is narrow and the body is simply wider, the pressure on the edges of the wound would be more, but it doesn't cut the tissue. So when it is in a soft tissue, this kind of needles are used. But if the tissue is harder, like the skin, then when you penetrate through the skin, harder surface of the skin with the round body needle, it requires more pressure and the damage is more. And hence, in such a situation, you use a cutting needle. Cutting needle where instead of the body being round, it will be somewhat prismatic, and these 3 edges will be cutting. And that's what Sushila has said as a Trasra. So the technology of having these kinds of sophisticated instruments also were known in Sushila's period, and this cutting edge needle can penetrate through the harder tissue easily, though it can produce some injury to the cells in the periphery. And of course, in the cutting edge, you may now have either outer edge and inner edge cutting, like different types of these cutting edges can be seen. Now, in addition to this, Sushila has mentioned about 2 varieties, either a straight needle or a curved needle. A straight needle, it can be used over the surface where you have a access to the movement, where you can move horizontally, whereas curved needles are used in case of deeper areas. Now that's exactly what Sushila has mentioned. Ayata, triangular, Trasra, Mamsala, Chapapujita. In the Mamsala, in a thick tissue, you will be using Trasra, the cutting needle, and in the surface of the body, you will be using Vritta needle, and Dhanurvakrahita Marmaphalakoshodharapri. Dhanurvakra or curved needle is used in case of Palakosha, scrotum or Udara abdomen, where comparatively the scope for the horizontal movement is lesser, and you use a needle holder and then curve the movement is achieved. Ityeta Trividha Suji Hitishnagраha Samaita Karayat Malati Pushpuruntagra Parimandalaha. The tip of the needle would be as sharp as that of a tender jasmine flower. Now, of course, in the present day situation, you may even in the cutting needle, you may have some more varieties like the half curve or 3/8 curve or 1/4 curve or maybe the J shape, and this kind of modifications are done depending upon the access to the area. When you have a free movement over the area, you will be tending to have a horizontal. When the movement is lesser, you will be using a curved needle, and depending upon the degree of movement and scope of the area, you may use either a half circle or 1/4 circle or so on. So these are the varieties of the needles which are used. In addition to these, Vagbhata has mentioned another of the technology where it's a atraumatic needle or Gudha-pasha. Gudha-pasha needle is mentioned by Vagbhata. Vritta Gudha-dhrudah pashe tisra suchatra sivane. Gudha-pasha is mentioned. In the Gudha-pasha, the advantage is the thread is not inserted through a open eye. Instead, the thread is inserted into a notch at the base of the needle, and then the notch is pressed so that the width of the needle and the thread doesn't increase at the area. Now, with the simple needle, where you use a eye is there, an opening is there, and through that opening, when you put the thread, as the thread doubles at that area, that becomes the widest area. So, needle tip is narrow, and the widest area is at the base, and hence that could produce a irregular tear, microscopic irregular tear at the area of the needle penetration, which can affect the tissue healing. Whereas with the atraumatic needle, where the needle is inserted, the thread is inserted into a notch at the base of the needle, there will be no increase in the depth. The depth change in the increase in the width of the needle, the tip of the needle and the base of the needle. The range of variation is lesser, and hence it produces lesser trauma, and these are called as atraumatic needles. In the present day situation, you will have similar atraumatic needles, but important is this kind of technology and fine considerations of the trauma to the tissue also were known at that period as such. Now, to do the suturing, how to do the suturing, even that technique also is described by Sushila very clearly, and the rule is nati dure nikristeva suchim karmani pateta dura drujaha vranastasya sanikristya avalancharam. When you have to suture a needle, the needle should penetrate through the tissue at the edge of the wound in such a way that it produces a uniform compression of the tissue edge of the wound, but at the same time should produce sufficient approximation. The whole target of the suture is to have a uniform this approximation of the wound edges. Now, to achieve this, you will have to consider the depth of the wound and the access to the wound area, the surface area as such. The general rule is if the needle should cover, even thread to cover 90 to 95% of the depth, and it should not be more than 2 centimeters as such. If it is more than 2 centimeters, then the tissue compression, the amount of the tissue which is compressed in between the two edges would be more, and hence the gap between the wound edge and the insertion of the needle on an ideal way should not be more than 1.3 or 1.5 centimeters. It's not millimeter, 1.5 centimeters. That's the maximum this distance between the edge of the wound and the point of insertion of the needle. And the needle should be brought out at the same distance on the other side. Now, if the wound, your suture doesn't cover the depth, then suppose if the suture is negotiated very close to the edge and you have left out a depth as such, then this depth will be acting as a potential dead space and it can result in hematoma. Or if the edges are not really uniform, on some side, on one side the penetration is more and others lesser, and the other side the penetration is more, then the wound edge will not have the uniformity, it will be just shrinking, and this also will result in improper healing. So in case of deep wounds, if it is more than 2 centimeters, then it's better to have a concealed suture at the base so that the depth of the wound is reduced, and then you put the suture as usual. So that's the usual rule, and same is mentioned by Sushruta as a nati dure nikristeva. So, and if at all the distance is more, the distance covered by the needle is more, then more tissue, more cells will be compressed, and the vascularity of these tissue will be affected. If it is very close, then the wound will dehisce. That's exactly what Sushruta has mentioned. In the present day situation, in addition to these suturing materials, you have other options like staples, tapes or the gums. These are the new varieties of the materials which are used for wound closure. They are not suturing. Of course, the advantages of this is comparatively somewhat lesser, or maybe the only advantage of this would be technology is used here, and the scar would be comparatively lesser. Compare it to the suturing materials. Now, threads and other suturing materials, the advantages are the technique is simple, it's simple, and it gives a good tensile strength, and it also produces perfect alignment. One of the major drawbacks of the suturing materials, thread materials, are one is many of these suturing materials would act as a foreign body, and then they can produce irritation and reactions can occur. Reaction with the suturing material and stitch abscess is quite common, and whenever you select the suturing materials, a suturing material which would have lesser reaction is always preferred. Now, in many of the synthetic substances like proline is known to have comparatively least reaction with the tissue, whereas cotton, it reacts with the tissue to the maximum extent. The reactivity of the tissue material would also be decided by the surface character. A rough thread would be having more reaction, whereas a smooth material would have a lesser reaction. And the other part is about the tensile strength of these materials also would be varying. Cotton has comparatively lesser tensile strength compared to the Suturing or the other synthetic materials like proline. So depending upon the type of the suture which you prefer, you will be using this. Cotton is always preferred because of its ease of convenience knotting, because it doesn't slip off. The knot doesn't slip off, and it gives sufficient strength over there. Compared to silk or nylon, the knot may slip off. And the nylon and silk, or maybe many of the synthetic materials also, would have more memory. Memory in the sense the thread will have that coiling property. Whereas in the cotton, it has the least memory. It can just stretch it straight and it will be easily flexible. So the properties of the suturing materials would be considered, and based upon that, you would be preferring. In brief, what I have to suggest, any of the suturing sutures which have to be removed, which can be removed later, like the surface, cotton is preferable. Whereas in the deeper area where the suture cannot be removed, so less reactive and the more synthetic substances could be used. Compared to these, the staples have an advantage of working fast. The time taken would be lesser and reactivity is lesser. Of course, it needs a technology of that specific instrument is required. Without a specific instrument, you cannot use the staples. Removal of the staples also is again requires a specific instrument. I don't say that very sophisticated. It's a sophisticated, somewhat different sort of instrument. The usual forceps and scissors would not help that. And you need to have practice. Without practicing, you cannot use the staples. Then tapes are comparatively very new and they are costly. And the major is virtually there is no scar. It's just over the surface, you put the tape and the wound edge is closed. And that wound tapes do not cover the depth. So that's about the disadvantages as such. So strength is lesser. But in certain areas, superficial wounds, tapes may be used. Tissue adhesives are very new materials which are introduced where gum is used, and they are known to have lesser scar and they are comparatively more comfortable, but they are costly as such. So choices would be based upon that. Now, after the suturing, the wound care has to be taken, and that wound care is Adakshama Pichuchannam Suskutam Pratisarayed Priyango Anyanestya Rodha Churni Samantha Shallaki Palachurnirva Kshoma Dhyamena Vapunaha Tato Vranam Yatha Yogam Badhva Acharikam Adisheta. After the wound, Shusha would suggest Pratisarana, applying some dry powder over there. Now, whether you apply some dry powder or keep the wound dry or dry gauze is used, that all depends upon the status of the wound. If it is a sterile and perfectly clean wound, better not to use any substances. If there is a oozing, then you have to have some absorbent material. Absorbent material, either it could be cotton or it could be any of the dry powders, dusts which could be used. And of course, about the ointments and other liquids, we have discussed that properties and uses in the earlier sessions. So the same is used. If at all there is a possibility of sepsis, or you need to have some medicinal effects over the area, particularly antiseptic substances, then you may use either an ointment or a liquid which could be used depending upon the discussion which we had in the previous session. Now, this is about the summary of the aṣṭavidhaśastrakarma. So, suturing or Sivana is the last of the aṣṭavidhaśastrakarma. Etu aṣṭavidham karma samasena prakirtam chikitsiteshu katsena vistarastasya vidyatvakshyate. So, these are the summary of the aṣṭavidhaśastrakarma mentioned in this chapter. Now, the complications of the aṣṭavidhaśastrakarma. Surgical procedures are known to produce the complication, and Sushruta has detailed these complications in a very clear-cut manner. The complications could be Shina, Atiriktam, Tiriyakta, Gatra, Chedanamatmana, Eta, Chatasru, Aṣṭavidhe Karmani, Vyapalasmraha. The 4 types of complications which can occur are Shina Yoga, where the surgery is done, but it's not done to the optimum extent. Suppose you are supposed to remove the appendix. Instead of removing the whole of the appendix, only a part of it is removed and a part is left over. That's the Hina Yoga. Atirikta is excess, then in excess, more than what's really required. So instead of removing the appendix alone, you have removed a part of the cecum even. That's the Atirikta. Tiriyak is a wrong technique, where instead of removing the appendix, you have removed the ureters or so on. So other structures, damage to other structures has occurred. So wrong techniques are there. And the 4th one, which is very interesting, of Sushruta is Gatra Chedanam, surgeon injuring himself. Now, surgeon injuring himself is quite a possibility, and this is quite possible because of improper hands and eye coordination, as well as this anxiety of the surgeons. If the surgeons do not have that surgical personality, a cool personality, or if the surgeons do not have a hands and eye coordination, there is a possibility of injury to the self. Now, these are the 4 types of complications which can occur during the surgical procedure. Sushruta gives some more detail like how these complications can occur. Ajnana loba ahitavakya yoga bhaya pramohehi apareshya bhavehi yatha prayunjit bhishakushastam tada sasvesham kurute vikaran. A hina yoga can occur, that's where a incomplete removal of the lesion could occur due to ajnana, ignorance, because you are not able to identify the anatomy. Then it could be like Hina Yoga. Or Lobha, a desire to have another opportunity to treat the patient. So if the disease is left over, if the lesion is left over, there could be a recurrence, and if in Sushruta period, the patient would have to come to Sushruta only. But now, of course, if at all such a situation occurs, the patient will go to some other surgeon. So that may not be practically true now, but in Sushruta period, because there are no other choices, it could be like. Then Ahitavakya Yoga, because of improper history taking and improper examination, and Bhaya Pramohehi, that confusion during the surgery or the fear during the surgery may be the cause for the Hina Yoga, incomplete removal. Or Ati Yoga is Tam Kshara Sastragrimihi Aushadhishta Bhuyo Abhivinyanam Ayuktayuktam Jijivishu Durateyo Vidyam Vivardeyet Ugra Vishahitulyam. A person who doesn't know the anatomy and gets confused and cuts more than what is required, Sushruta says such a surgeon should be avoided by the patient. Sushruta advises the patient and avoid such a surgeon like Ugra Vishahitulyam, like a serpent with the very strong poisons. He has to be left over if you are interested in surviving. Tadeva yuktam tu atimarma sandhin himsyat siraha snayamata atha asti chaiva. Murkha prayuktam purusham kshanena prani vijyat athava kadachita. Ati yoga, it can be now this Ugra Vishahitulyam is about Tiriyak yoga, wrong techniques. Those who do not have the proper techniques, they should be avoided and they can kill the people. Whereas Ati yoga, the person is considered as Murkha, ignorant person, and he can even damage or even produce fatal complications, and such a person also has to be avoided. Then the complications other which can occur to the patient after the surgery or during the surgery would be Brahmaha, Pralapaha, Pratanam, Pramoha, Vichestram, Samlayana, Usnateja, Sastangata, Murchanam, Urdhvataha, तीव्रारुजो वातकृताश्च तास्ताः मांसोदकाभं रुधिरिन्त्य गच्छेत् सर्वेन्द्रिय अर्थोपरमस्तथैव दशार्धसङ्ख्येष्वपि वीक्षतेषु सामान्यतो मर्मसु लिङ्गमुक्तम्. The complications which can occur in the postoperative period, which can be due to any of these issues or due to other complications of the disease, primarily the stress-induced, surgical stress-induced or pain-induced or hemorrhage-induced complications are brahma, giddiness, pralapaha, confusion, patanam, that's the patient may fall and the injury due to the fall, or pramoha, impaired consciousness, vichestanam, irregular movement in later period, samlayanam, damage to the wound, ushnateja, the fever or the complications or signs of inflammation, srastangata, damage to the organ, a part of the body, and hence that damage would be visible. Like srastangata is like suppose you have this repaired hernia and the vessels are blocked. So, and the patient develops ischemia later. That's the srastangata. Murchanam, unconsciousness. Urdhvataha, that's a obstruction to the gastrointestinal tract. Patient may have a paralytic ileus in the postoperative period. Tivrarujaha, severe pain, or mamsodakabham rujiramcha gaccheta. There could be bleeding, or either a fresh blood or a serous fluid could be lost as such. Sarvendriyartha uparamaha, patient may have the loss of sensations. All sensations could be lost in the postoperative period. Or any of the marma vidha lakshana could occur. Marma vidha lakshana, as in case of the 5 types of the marma, either sadhya pranahara, kalantar pranahara, all these dashartha sankhya, 5 types of those marma vidha lakshana could occur in the postoperative period. Bleeding is one of the major complications which can occur in the postoperative period, and Sushila gives the stress upon that part. Surendra Gopa Pratimam Prabhutam Raktam Sruvet Kshatrascha Vayu Karoti Rogan Vividhan Yatoksan Chinnasu Bhinnasu Athavasira. So the complications of the bleeding in the postoperative period are one of the major complications which could occur, and hence you have to be careful, and their signs have to be noted, and early treatment has to be introduced. It is started as such. The complications which can occur due to that impaired hemostasis or bleeding could be Kaubhyam, Sharira Avayava Avasadaha, Kriyasu Ashaktihi, Tumala Rujascha, Chira Guranaha Rohati, Yasyachapi, Tam Snayu Manajam Vyavastheta. If there is a snayu with injury to the snayu tendons, then it can result in tendons and muscles in that muscular structures. Then there could be deformities, visible deformities in the postoperative period, or any part of the organ would not be, any part of the body, like a limb may not be functioning possibly or properly, and Kriyasu Ashaktihi, the functions may be impaired. Tumala Rujashta, pain could be more, and the wound will not heal in the proper time. That's the signs of the tendons and ligaments being injured, a collateral injury of the surgery. So bleeding, injury to the muscular structures is another of the complications. Another of the complication would be injury to the still deeper structures like the joint and the bones. In that condition, Shopati Vriddhihi Tumula Rujascha, Balakshayaha Parvasu Bhedashopo, Kshatesu Sandhishu Achalachaleshu, Syat Sandhi Karma Uparatishtalingam. If the joint is affected or the bones are affected, then there could be severe swelling, and of course the pain will be more severe. Balakshayaha, all the strength of the limb would be affected, and there could be pain and swelling in the joints as such, and or it could be over the wound, kshateshu, either in the parvasu or kshateshu. It could be in the joint or in the wound, the pain would be more, and sandhi karma uparatihi, the functions of the joint would be affected as such. Aṣṭavidhaśastrakarmīyādhyāyaḥ, if there is injury to the bone, ghora harujaha yasya nishadineshu sarvasu avasthachu shantirasti Tishnanga sadha ukshayatuscha rukta tamaste vidham panjam vyaseta. If there is an injury to the bone, then the pain will be very severe and it could be continuous pain. Patient would not find any comfort in any of the positions. So patient would just have roll over the bed. And of course, in case of the bone injury, one of the issue is a patient would adopt a position which will be a sign, clinical sign of the evidence of the disease. Like a patient with a fracture of neck of the femur would keep the leg abducted, and that itself is a clinical sign. So sarvas avasthas nashanti res asti, in the sense patient would find himself a position which can be identified as the sign of the disease as such. So diagnosis by the looking at the position of the patient. Trishna angasadha, signs of shock like excess of thirst and shayatu, the pain could be seen as such. Yathatsvametani vibhavecha lingani marmasu abhisaditeshu. The marmas, if there is a injury to the marma, as we have studied in the marma as such, the signs should be seen. Sparsham janati vipanduvarnaha yo mahamsa marmani abhisaditasyat. So general, specific as such would be, if there is a mamsa marma involvement, patient may have loss of sensation and the color of the body, the patient would look pale as such. So that's about the marma with the lakshana. Then the last part is atmanam eva atha jaganyakari shastrena yo hantihi karma kurvan tam atmavan atmahanam kuvedyam vivardiyetu ayuhu abhipsamanaha. A person who injures himself, a surgeon who injures himself during the surgery, he is considered as jaganyakari. He is considered as a useless fellow and who doesn't do the functions properly. And in such a situation, such a surgeon should be avoided by a patient who would be preferring to live. Ayuhu abhipsamanaha. If you are preferring to live, avoid that kind of a surgeon. Then Triyak Pranite Shastre Doshaha Puru Mudahatah Tasmat Pariharam Doshan Kuriyat Shastranipadanam. A wrong techniques, we have already detailed that all that possible complications of the wrong techniques where any other tissue could be injured and collateral injury could be more, and such complications should be avoided by a proper training as such. Now, in the current situation, the picture about the surgical complication is slightly different, but still the complications are quite important, and a practicing surgeon should be aware of that. Now, when we now consider as surgery has become very sophisticated, technology has been quite common, and incidents of surgical operations are increasing. Like in the present situation, the complications also are quite significant, and complications like death in the postoperative death is quite significant among the different causes of the death in global data. This is about the global data. I have the reference over there. Almost 7.7% of the total deaths are produced due to the postoperative complications. It's not only the death. There could be other complications of the surgery, and this is about the latest data which is published in 2018. Published in 2012 to 2018, that range, the 4 years. Now, the 6 years, the issue is the surgery now is considered to be very safe, and the technology has introduced that surgery or has made it quite prevalent. And USA is considered as a country where all the techniques or technologies are used to the maximum extent. Still, the complications of the surgery are still quite high. Now, I said about 7.7% of the total post-operative deaths is the post-operative death, and that death complication is at the base. This red line is about the death, right? Now, sorry, this line, the gray line, is about the death. This is suggestive about the death. But the other complications, like the surgical infections, surgical site infections, are still quite high. They are not lower as such, though they are reduced to a certain extent in the past 6 years, where you have all that sophisticated technology, new generation of antibiotics. Still, surgical site infections are still common, and they constitute a very significant component of the postoperative complications. So, from that point of view, now the question is whether antibiotics are needed in the postoperative period, how far the antibiotics are safer or not. These are all the basic discussions which are to be considered. But I have experienced, and with the teaching from Professor P.J. Deshpande in Banaras, it's not the antibiotics which can prevent the surgical site infections. It's about the tissue injury. If there are lesser tissue injury, then the wound will heal, infections will be lesser. If there is more injury, then infections are more. So when I do the surgery, you might have observed, I do not use a pincers, I do not use a forceps to put the suture. The purpose is when you use a forceps, there will be some damage to the cell, and this damage to the cell will be counting a lot. When you use more instruments, that again will result in more injury. So lesser instruments would produce lesser injury, and that makes the difference in the surgical site infections. So surgical site infections, if at all you have an idea like administration of the antibiotics would prevent surgical site infections, that's not true, because with all that sophisticated techniques, even in a country like USA where you have the maximum sophistication, still it's the incidence is more. Incidence of surgical site infection is more, and hence this fact has to be kept in mind. And from Ayurvedic point of view, Ayurvedic surgeons, you need to keep that consideration of respecting the tissue and the tissue injury being minimal as such. Now, because the surgery has led to such a complication, the practicing surgeons should be aware of these developments also. WHO has taken a agenda of safe surgery, and the reason there is a huge movement about safe surgery, and that safe surgery sponsored by WHO, and it has given the guidelines for the safe surgery, and it has become a vogue in throughout. And the reason for this movement is the incidence of the complications are quite high in majority of the countries as throughout the globe. Now, WHO has given some guidelines, 10 guidelines, 10 essential objectives for safe surgery, and this is should be known. I don't say that they are very huge, significant issues, but compared to what Sushil has mentioned, these are all the repetitions of what Sushil has mentioned, but presented in a different language and a contemporary idea, and hence everyone should be knowing that. And those 10 essential objectives of the surgery are: the team will operate on the correct patient at the correct site, because incidence of a wrong surgery on a wrong patient is increasing, because now surgeons have become what we call as a suitcase surgeons. Say surgeons do not see the patient in the preoperative period. Somebody else sees the patient in the preoperative period, and the patient is taken to the OT. Surgeon visits the hospital and does the surgery. Such a thing would be creating the most complications of a improper surgery in this wrong patient as such, and these kinds of incidents are increasing. So it's always essential that a surgeon should examine the patient prior to the surgery, and surgeon should have a mental exercise, exercise of how to do the surgery in that particular patient, considering all the variations there. Then the team will use methods known to prevent harm from administration of anesthetics while protecting the patient from pain. Team will recognize and effectively prepare for life-threatening loss of airway or respiratory functions. And the team will recognize and effectively prepare for risk of high blood loss. The team will avoid inducing an allergic or adverse drug reaction for which the patient is known to be at significant risk. The team will consistently use methods known to minimize the risk of surgical site infections. Team will prevent inadvertent retention of instruments and sponges in surgical wounds. The team will secure and accurately identify all surgical specimens. Team will effectively communicate and exchange critical information for the safe conduct of the operation. Hospitals and public health systems will establish routine surveillance of surgical capacity, volume, and results. These 10 objectives of safe surgery are simply whatever we have discussed. Repetition may be presented in a different manner, but because it is a contemporary idea and a program of WHO, every practicing surgeon should be aware of these issues. Now, another issue is about the checklist. If at all you are planning for surgery, there has to be a surgical safety checklist, and surgical safety checklist is again recommended by the WHO. The copy of that, of course, what we have in our OT is a modification of the same. It's modified. Anyone can modify, have the right to have the modified, but the checklist is important. Surgical resources and environment. Trained personnel, clean water, consistent light source, consistent suction, supplemental oxygen, functioning surgical equipment, and sterile instruments. These are the basic requirement of the surgery. Of course, the same presented in a different manner. Now, I stress upon this, repeat this, because whenever you do the surgery, go for the surgery, you should be well prepared for this, and all these necessary things have to be kept as such ready. It's not how this extravaganza which is the important thing, but it's about the safety of the instrument and the minimum required is the issue. Surgeon is the captain of the team, and hence for any lapse he is accountable. He cannot put the blame on anybody else as such. So if anybody else does commits an error, still the surgeon is accountable, and that fact has to be kept in mind. Now, as per the WHO, the access to the safe surgery throughout the globe is not uniform, and India is one country where the safe surgery access is lesser. Now, this dark color suggests about poor access to the safe surgery, and hence those who are in the field of surgery now should be aware of these developments, and there is a lot of effort by the administration to increase this access to the safe surgery, and particularly in the context of permitting Ayurvedic surgeons to do the surgery as per the latest Gazette notification. This issue is one of the issues in the background to give more access to the safe surgery to the population, and Ayurvedic surgeons have to be aware of these issues related to the safe surgery as such. That's all my idea. I'm not going into detail of these issues, but my purpose is sensitize about these issues, and Ayurvedic surgeons should be aware of that. With this, next, Mataram Pitam Putram Bandhavan Apitraturaha Apietan Abhishanketa Vaidya Vishwasametja Visjati Atmanatmanam Natinam Parishankate Tasmat Putravadenam Palayat Aturam Bhishaka. A patient who comes for the surgery, he is totally committed to the surgeon. The surgeon has that burden of taking care of a patient to that extent, and in such a way that like the issue commitment of a patient to the surgeon is so high that a person may suspect any of his close relatives like mother, father or child, but over the surgeon he will have all that complete belief, the faith, and that faith on the surgeon is more than the faith on the God. Because when you go for a worship to the God, you will not expect a pain, you will be always expecting something better. But when you go to a surgeon, you will be knowing that there will be some pain, but in the long run there will be some advantage, benefit. So that kind of a dual approach where you are ready to accept the pain and expect something better, this kind of a faith is only with the surgeon, and surgical field is such a issue where you need to have that commitment of the patient, and that for that commitment of the patient there should be reciprocation by the surgeon, and that reciprocation, Sushruta says, Tasmat Putravadenam Palayat Aturam Bhishaka. So you have to treat a patient as if the patient is your own progeny, your own son or daughter as such. Dharmartam Kirtimatyaktam Savam Grahanamatam Prapniyat Sarvatum Jahitam Arabhya Karmana. So a practicing surgeon would have all the advantages of gaining all that the facilities of this world, Dharma, Artha or Kirti. You will also have a good name, is possible. Satam Grahanamatam, acceptance by the are respected by the society and this world. At the same time, a surgeon is ensured of a position in the heaven. So when you go to heaven, a surgeon will always go to heaven as such. So that's the advantage of being in the surgery. Then the last part is Karmana Kashchite Kena, Dvabhyam Kashchit Tribhistatah, Vikara Sadhite Kashchit Chaturbhishapi Karmabhi. Though aṣṭavidhaśastrakarmīyādhyāyaḥ are mentioned and the diseases are classified as Chedya, Bhedya, Yesha, etc., a disease may require more than one or two procedures as such. This is a point which we have discussed in the beginning also. Like an example, Arbuda, you have indication of Visravana, Chedana. So, Arbuda is a Visravi Vyadhi or Chedya Vyadhi. There is no need of confusion. It's about the stage in which you have seen. If the Arbuda is seen in early condition, Visravana could be the option. Chedana is the later option, or similarly, Granthi in the initial stages, it could be the Visravana. And when it is having separation, it's a Bhedana. When a non-separated Granthi is seen, Amarmajatam, Shamam Aprayantam, if it is not in the Marma or it doesn't subside to the usual treatment, then Chedana is indicated. Similarly, in all the other conditions. So whenever we classify a disease as Chedya, Abhedya or so on, It all suggests about the indications in a specific stage, but it's not an absolute classification. With this, we'll end this chapter. It is Sushil Samhitayam Sutrasthane aṣṭavidhaśastrakarmīyo nama Panchavimsho Adhyāyaḥ. Summary: classification and details of surgical techniques is extensive. Right technique in right condition at the right time is the key to safe and successful surgery. Safe surgery is a major global concern today, and we need to be sensitized about it. Principles of Sushruta can give a promising new outlook to the issue. With this, let us conclude. If there are any questions,